Today we welcome Dr. Don Iverson, lead author of the AAN's newest guideline titled Practice Parameter Evaluation and Management of Driving Risk in Dementia and Evidence-Based Review.
Thanks. Thank you all for coming. I wanted to just kind of put it in context and give everybody an idea of the scope of the problem that we're dealing with. There are about 400,000 people in Canada who have dementia and about 4 million in the United States. The incidence of dementia increases with age. Between age 65 and 74, about 2.5% of the population has dementia. By the time you're over 85, nearly half of the population has dementia. And since the population in the United States and Canada is aging, this means that the problem will continue to grow. The Canadian Medical Association states that by 2028 there will be 100,000 drivers in Ontario who are suffering from dementia. Dementia is a common problem. There are probably people here in the audience whose lives have been touched by it, and it really has a huge impact on patients and families. And just receiving the diagnosis of dementia is the first of many blows that the patient and family will have to suffer. That brings up discussions of a lot of uncomfortable issues, including end-of-life care, transitions to other types of assisted living situations, driving cessation, financial conservatorship, a lot of unpleasant issues. And these issues can really tear families apart at times, and it needs to be handled sensitively. Dementia is different, really, than other types of illnesses that affect aged people. It erodes at really the essence of a person, their personality, their intellect, their ability to socialize, interact with others, and their autonomy. And it's almost dehumanizing in a way. And this, again, needs to be considered, and usually is considered by clinicians who are caring for patients with dementia, because it's just an awful, relentlessly progressive and usually incurable terminal condition. The loss of autonomy, I think, is particularly hard for patients of this generation. Tom Brokaw calls the greatest generation. These are people who went through the Depression and Dust Bowl, World War II, Korean War. They're very self-reliant people. They're hesitant to ask for a handout or for help. They've been driving for 50 years. This is just a huge part of somebody's life. They've spent literally years sitting in a car, and to have to face giving up the keys is an admission of their mortality. And again, it's a huge deal. The sad truth is that as dementia severity progresses, there is going to be a point where a person is going to be unable to drive, and that doesn't happen in a single day. There's no black and white transition from safe driver to unsafe driver. It's a gradual process. And what we're trying to do with this practice parameter is identify characteristics that identify patients who are at higher risk for unsafe driving, and present information to the patient and the caregivers so that there can be a transition from driving to not driving. On the one hand, the clinicians want to protect the public health and the patient's health and not have unsafe drivers on the road. On the other hand, we want to preserve the autonomy when it's appropriate. When patients lose driving privileges, it's associated or can be associated with worsening of depression and actually shortened life expectancy. So we're trying to strike the balance. I want to talk a little bit about how these guidelines come to be and how they differ from a basic review article. The Quality Standards Subcommittee of the American Academy of Neurology writes practice parameters that are evidence-based, so-called evidence-based, or based on systematic reviews, where we review the literature and grade the evidence and grade the studies according to the level of bias or potential level of bias of the studies. We set the bar high, and only studies that meet those criteria are considered to base recommendations upon. We reviewed over 6,000 articles or abstracts for this study, making it the largest study of the topic to date. Wanted to just discuss what constitutes an unsafe driver, or what outcome measures did we look at. There's a lot of focus on crashing, and you could look at crashing, you could look at performance on an on-road driving test, or performance in a simulator. If you think about crashes, that they're not necessarily sensitive or specific for identifying an unsafe driver. In other words, some of us, myself included, have had a crash. It was my fault, and that doesn't necessarily mean that my license needs to be revoked. On the other hand, there are people who are unsafe drivers who fortunately have never been in a crash. So that and the methodologic issues of gathering the data mean that the crash data are not what we consider to be the gold standard. What we consider to be the gold standard is performance on a standardized on-road driving test. That is the de facto legal determinant for driving ability. The first question to face is, are patients with mild dementia unsafe drivers? And we define mild dementia based on in this setting, on the basis of what's called the Clinical Dementia Rating Scale, which I think is in your handout. And it's a little confusing because the CDR refers to moderate difficulties in daily living, moderate, but we're calling it a mild dementia. So I apologize for the confusion, but we're talking about patients with a CDR score of 1. And are these people unsafe drivers? You can kind of look at the data two ways. If you imagine kind of two talking heads from the right and from the left, the people on one side can say, there's a relative risk of failing a driving test that's 12 to 88 times the control group. In other words, people with dementia are 12 to 88 times more likely to fail a driving test, and that sounds pretty bad. On the other hand, some studies show that 76% of patients with mild dementia were still able to pass a driving test. Another one, 41% passed. And in another study, 22% of the control group failed the driving test. These are, assumedly, quote-unquote, normal people. So you see that it's hard to come down with a categorical statement on this. We can say that there's definitely an increased risk, but there are a lot of people who are still able to drive safely. And the conclusion that we came to kind of balance both sides was that patients with mild dementia should strongly consider discontinuing driving. So when I have a patient with dementia in my office and I want to get more information, the first thing I do is ask the patient and their family, what do you think of your driving? This comes up when we're just even establishing a diagnosis of dementia. We ask about memory and orientation and so forth, and a lot of times we'll ask the patient, and the family, how's the driving going? Are they able to navigate? Do they get lost? Do they have trouble finding their car, and that sort of thing? So the door's opened a little bit with the initial intake. But if you ask a patient, how well are you driving? And they say, fine, everything is fine. That doesn't help you. In fact, this was the strongest evidence we found that a patient's report that they are driving fine is not helpful, is not correlated with their driving ability. So it has to be disregarded. Most of the time, if a patient recognizes that their driving is deteriorated, they've stopped driving, but there are some patients who will acknowledge that they're not driving as well as they used to. And that's helpful, and I'll talk a little more about that later. Really, a big thing is the opinion of the caregiver or an observer. And I'll ask somebody, have you driven with this person, and what do you think? If they say everything's fine, it's not a problem, again, that doesn't help you. That doesn't correlate very well with the actual driving performance. Caregivers may be trying to protect the patient. They don't want to rat them out. They don't want to have to bear the burden. They may be in some sort of denial. So that, when the caregiver says everything's fine, doesn't help. If the caregiver says, I'm concerned, I'm afraid to drive with him, that really pans out. When you administer driving tests to these patients, they don't perform as well. And that was the highest quality evidence that we found in terms of identifying additional driving risk, was that the caregiver report that the patient is marginal or unsafe is definitely valid.